Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. Allahumma inni as'aluka ilman nafiyan rizqan tayyiban wa amalan mutaqabbala shifa min kulli da. This is Dr. Zunaira Faiz. Today the topic of discussion is uterine fibroid. Uterine fibroids. They are benign tumors of the uterine smooth muscles, common 25% of the women in a lifetime, usually multiple, various sizes, genetic predisposition, that is, if there is family history of the uterine fibroid in the sisters, in the first cousins, there is a chance to have the uterine fibroids. More common in black races, more common in obese women, less common in smokers, more common in nulliparous, accounts for almost 30% of the hysterectomies. If you see after the hysterectomy the uterus and you cut in this section, you will appreciate the presence of multiple fibroids. Now, as far as the fibroid locations is concerned, we have subserous fibroids project from the uterus into the peritoneal cavity, sometimes pedunculated, least likely to cause symptoms. Submucous, that is 5% of all the fibroids, project into the uterine cavity, sometimes pedunculated, most likely to cause symptoms. These are the fibroids which cause symptoms, that is menorrhagia, recurrent abortions, preterm labor, like that. Intramural, that is which is present, these fibroids, they are present in the myometrial wall, in the myometrium of the uterus. Most common, usually multiple. Intramural and submucous fibroids. If you see the picture like this, you can appreciate the presence of these are the fibroids. Fibroids tumor may occur in the various regions of the uterus. This is to show, you can see in picture. Subserous fibroids at laparotomy, at laparoscopy you will see. It will look like this. Uterus and it's a fibroid and it's a tube. This is a view during laparoscopic examination. Regarding the symptoms of the fibroids, mostly asymptomatic. Patient comes to the gynae clinic for some other symptoms, and incidentally on ultrasound she is found to have the fibroids. Menorrhagia, excessive heavy menses, heavy regular periods. Periods are regular, coming in time every month, but blood loss is more as compared to the routine, the previous cycles. Iron deficiency anemia is because of the heavy blood loss. Pressure fits, that is urine frequency. Fibroid causes pressure on the urinary bladder, so the patient has urge to go to bathroom again and again. Pelvic tumor awareness, that is patient feels some pressure. Difficulty initiating micturition sometimes. Pain, infertility, and irregular vaginal bleeding is the outcome. Maybe due to other pathology. Now, fibroids natural history. Estrogen-dependent tumors that grow slowly while cycling premenopausal, probably while on combined oral contraceptive pills containing estrogen and progesterone. When taking estrogen, that is hormone replacement therapy, will regress with menopause. Response to progesterone-only contraception is uncertain. Malignant change rare, that is less than 1 into 1000. Investigations of the fibroids. Ultrasound is the mainstay of the diagnosis. Frequently misdiagnosed with this modality. Multiple small fibroid is usually irrelevant. Heterogeneous echoluscency is normal in a parous uterus. Adenomyosis can look like the same. So, if you see an ultrasound, sometimes if the fibroids they are small, the small fibroids they mix with the adenomyosis. We have to differentiate it by the clinical history, by the internal examination. Heterogeneous echoluscency is normal in a parous uterus. It is a normal in the multiparous woman. Size and location is very important. Can be contraction wave in pregnancy. If you see in ultrasound, sometimes the myometrial contraction wave, it will mimic like the fibroid. MRI better than CT imaging. Laparoscopy and hysteroscopy. Saline hysterography, that is, you inject the saline in the uterus, and meanwhile we will do the we do hysterography, and we can appreciate the presence of the fibroids by irregular when we see the irregular endometrium lining of the uterus. Useful for the pedunculated submucous fibroids. Investigating a submucous fibroid. You see in this picture, this is a big fibroid. Again, it's more clear here because it is labeled here. You see the bladder, cervix. It is the cavity of the uterus. It is pushed up interiorly, and this is the fibroid. You can appreciate big in pink color. Again, it is the laparoscopic view. You can see the fibroid here. Investigating a submucous fibroid, that is, you see in this picture, this is the fibroid, this is the, again, you can see this is the fibroid and this is the endometrium. This is endometrium, fibroid, endometrium, fibroid, which is lined by red line. And this is laparoscopic view, panoramic view, you can see the fibroid. Treatment options for the fibroids. Hysterectomy, removal of the uterus. If the uterus is more than 10 weeks or symptoms that are due to the fibroids, rapid growth, abdominal or the vaginal hysterectomy we can do. Second option is myomectomy, that is uterus is preserved but only the myoma, that is fibroid, is removed only. Best for single fibroid in a young woman. Almost 50% come to the hysterectomy within 5 years. Yes, this is question mark. Hysteroscopic resection, which is very common nowadays. Uterine artery embolization, yes, it is being done in Lahore in Pakistan also. Medical options are there, but again, these are not permanent medical options. That is gonadotrophin releasing hormone analogs. These injections, they are very costly, and usually we give one injection per month for consecutive 3 months, and it has its own side effects, and we have to give add-back therapy of the calcium and other tonics also. Mirena, levonorgestrel, that is intrauterine system. We have to, this is also successful, but provided the fibroid size is very small. Nice recommendations for the uterine fibroids. For patients with heavy menstrual bleeding and fibroids more than 3 cm size, and especially those with pelvic pain or other symptoms, then hysterectomy, uterine artery embolization, and myomectomy should all be offered. Myomectomy recommended if the fertility is desired. Hysteroscopic resection of the entire fibroid with endometrial resection is appropriate if the fibroids are submucous. Pre-treatment with gonadotrophin releasing hormone GnRH analog for 3 to 4 months is worthwhile before hysterectomy and myomectomy. It will reduce the size preoperatively. Reduces uterine size and makes surgery easier. Better hemoglobin preoperative buildup and less bleeding, of course. But GnRH analogs, they are contraindicated before uterine artery embolization. Fibroids and infertility. In most women, the association is result and not cause. It is said that 3% of the infertility is due to fibroids. Most infertility specialists will recommend removal of any fibroid with more than 50% of its surface in the uterine cavity. The results from the removal of a single submucous fibroid can be dramatic. And there is evidence that removal of the intramural fibroids more than 5 cm diameter will enhance fertility with in vitro fertilization. Fibroids and pregnancy. In most women, there is no effect. 80% remain unchanged in size, rarely rapid growth and red degeneration. Increased risk of bleeding and threatened preterm delivery, but most deliver at term. Fibroid in the lower segment can interfere with vaginal birth. Yes, and this can be one of the reasons of the cesarean section in these patients. Myomectomy at the time of cesarean is not wise because it will cause heavy bleeding. And one thing is, if there is myomectomy already because of removal of the fibroid in the non-pregnant state, then that woman should always have the elective cesarean section. Because of the scar of the uterus, she has to undergo the cesarean because we cannot give the trial of that scar during labor when she becomes pregnant. Moreover, the most important thing, which is red degeneration, I want to explain this term. This is the necrobiosis. Necrobiosis of the fibroids may occur at any time, but is most often seen during pregnancy or after menopause. If we see the degenerations, the blood supply to the fibroid enters from the periphery and central area is relatively deprived of circulation. Therefore, a large or rapidly growing fibroid, they can easily undergo degeneration. A number of degenerative changes they can occur in a fibroid. They include, number one is the hyaline degeneration, fatty degeneration, red degeneration. As I told you, it is occurring during mostly in pregnancy and in menopause. And then is the calcification. Again, it is also seen in the after menopause. And sarcomatous changes, because it is the malignant change which usually occurs in the center of the tumor, and diagnosis is generally made on histological examination of a removed fibroid. Sarcomatous change in a fibroid must be suspected if it undergoes rapid growth and becomes painful and tender, especially in a post-menopause woman. So we have to see the complications and these degenerations of the fibroids. We have to look after in the management of the patient. 30% usually require emergency hysterectomy. With that, I ends up with this lecture. I hope you understand and it will help you in your future study. Jazakallah khair.